Hello, I'm Michelle Needens. I'm one of the social workers at KU Alzheimer's Disease Center in the Cognitive Care Network. We're going to talk about a topic that I think is kind of tough to talk about at times. It's a topic that I know is important and I know affects many of you. And I also know many of you will feel that it's difficult in terms of asking questions about or understanding about. I know for some of you, it is a personal struggle. And I know for some of you, there is sadness and pain associated with that and difficulty in knowing who and to talk about it with. And so important topic for us, and that is the impact of dementia on sexual expression. Now, we are really talking about the impact of moderate dementia on sexual expression. We don't anticipate significant changes when we're talking about those earlier stages. And there can be some exceptions to that. And certainly in dementias like FTD behavioral variant, we may see some of the challenges that we talk about with the moderate stages of some of the other dementias. So you can decide for yourself what fits for you. But as a rule, we see this kind of behavior arise and the challenges associated with it in the moderate stage. Now, there's a host of contributing issues. One, of course, is the loss of filter, the disinhibition that occurs in middle stage as frontal lobe is affected, and we begin to see serious impact on all areas of executive function. So there's no protector between thought and action, as you and I have. And so if something creeps in the mind, there may be an action. And that may be in context and it may be out of context. Confusing strangers or others with loved ones. Seeing if they're in a long-term care facility, for example, they may see another resident and believe their spouse or girlfriend, etc. It could be confusing son with husband. So we see this misidentification occur, and that can be a contributing issue. Boredom is a big one, and you think, gosh, that makes no sense in terms of sexual expression, but it absolutely does. The more bored people are, the more they will give way to this phenomena of thoughts into actions. So we can direct people's thoughts oftentimes simply by the kind of activities and the involvements we have them in during the day. And we're going to say more about that here in a bit. Inability to recognize physical space, that as we see changes in visual spatial field and really understanding where we are physically and nature in the context of our world around us, people can be too close in proximity. Perhaps we've all known stories of or families or friends who have had loved ones in facilities who maybe crawled in bed with somebody else. Maybe that was related to a sexual context. Oftentimes it is confusion that it's really not about, it's not only about not about sexual expression, it's not about intimacy, it's simply about confusion, and that there's no logic in terms of if somebody's in the bed, I can't get in the bed. So sometimes we misperceive, and probably truer in the long-term care realm than at home, what we define as sexual expression, or even what we define as intimacy. Discomfort, and you think, gosh, how would that relate at all to sexual expression? Again, as physical messaging begins to be problematic in terms of translation. In other words, how people translate their physical messages. For example, people can have just eaten a meal and say, when are we going to eat? Not recognizing they're full. or you can say it's time to eat lunch. I just ate, and they're not recognizing hunger. Well, that can get mixed up in terms of all kinds of things. If I'm uncomfortable, then maybe it sends some other that physical message sends some other cue to us that's misdirected. Inadvertent caregiver or environmental cues such as television or a hired caregiver wearing low-cut shirts or visitors wearing, tight clothes or that kind of thing. Individuals in moderate stage are increasingly dependent on external cues, and there's many ways to use that for benefit as we want to support security and reassurance. But it certainly can guide into more difficult behaviors. So if you have a hired caregiver, you absolutely want to address that, and not in terms of accusing or judgment, but certainly in terms of indicating that it might be an external cue for inappropriate behavior. So, and the same with television. People can be watching a show, you're in the room doing something else, another show comes on. We just need to pay attention to the context of the external cues. Misidentification of social cues. So people become less and less aware of and responsive to social cues. So place might not matter. People can, masturbate in public spaces, for example. People can make inappropriate comments in public environments, that kind of thing. That social cues perhaps are not are no longer familiar to them, or something that they can interpret. Anxiety, that's one of those things like boredom, that when people are anxious, it moves you to being restless, and that may guide to some of this direction. Forgetfulness and confusion, can't remember frequency. So just like we talked about a few minutes ago, that someone can have just eaten and not remember they eat, and so they're saying, yeah, I need a second lunch or whatever. That can happen with sexual expression as well. And so that's not uncommon for us to see a demand for frequency go up. And then just the element of loneliness and the need for connection. There's some changes in connection. And when we see moderate stage, the person remains, they always carry with them their history and relationship. And we see so many beautiful aspects of individuals in these stages that exist for them always, and new beautiful things emerge. But there's some tough stuff, and that's undeniable. And some of the tough stuff is that we lose part of those relationship elements, and people feel that. So individuals with the disease can become lonely, feel emotionally lonely. Oftentimes we see physical contact diminished to direct care. So, bathing, toileting, those kind of things. And the closeness of that, a physical touch can diminishes. So, this sense of, I need to be connected can emerge. Spouses can certainly struggle with many things in this process. Can be those increased sexual demands that we talked about, that whether it be not remembering the frequency, or with something like FTD behavioral variant, very common for just those demands to increase, and that can become problematic. We're going to talk about possible responses here in a bit. You may have mixed feelings about intimacy. So maybe that person is initiating, but you don't feel like it's right because of the level of their confusion. That because of the mental incapacity. that somehow it feels like taking advantage of a person not capable. And at the same time, perhaps wanting that intimacy yourself. And so it's very common to have mixed feelings and to really not know what's right or what should be in these kind of experiences. Awkward sequencing of sexual activity as procedural memory gets implicated, and fine motor coordination and all that kind of stuff gets affected. Requests for activities not normally performed, and again, maybe externally cued or maybe because of the disinhibition. I have had some spouses say that that's a positive in some respect, but it certainly can be a negative. Lack of regard or consideration for you as spouse, that again, it's that missing of social cues. So figuring out you're tired, you're not interested, those kind of things, that the person's hurting you. They may not recognize roughness, etc. So some of that can happen. Your own loss of sexual interest, that once you began to take over some of the direct care needs, for example, toileting and bathing sometimes, there's just a loss of sexual interest. I would say that's true for many, many spouses. For those of you where that is not the case, that's, there are certainly those as well. So that, it can be all over the place in terms of that interest, but I don't want you feeling guilty if you say, gosh, that's just not anything I'm interested in. And if someone's in a long-term care facility, a person can connect with someone else there. And so to be prepared for that, feelings live through this disease process. Love stays in the room. The need for physical affection stays in the room. And so not unusual for someone in a memory care unit to befriend and, engage in intimate acts with another resident. So that can be holding hands and hugging. It can be crawling in bed with the person. There certainly has been occasions where sexual activity or sexual expression occurred. And again, it's not about infidelity in some way. It's about this loss of logic and reasoning. Sometimes it's simply about their misperceiving that other resident as their spouse. But other times, the spouse can be, a person can be holding hands with their spouse and also holding hands with this other resident, and to them it makes perfect sense. And then I know for some of you, there's real grief around the loss of intimacy. And I don't mean just sexual expression. I mean that intimate relationship one has with their spouse. And really finding someone you trust, whether that be in support group, etc., that really gets that, understands that. We grieve lots of things along the way. We don't grieve a disease. What we grieve is all the little pieces that are missed along the way, and this is one of them. So if we are trying to limit unwanted sexual advances, what should we do? How do we handle that? One is keep the person physically active during the day. Now, everybody has different, medical issues and mobility issues and etc. But as physically active as someone can be, we want to make sure each day has some sort of physical activity, especially if they're inclined at a stage where we're seeing some of these unwanted sexual advances. So they need to be walking. If they have a hired caregiver, they need to be working with them on doing things, working outside, as I said, taking walks, doing exercising with them. But there needs to be, doing chores that take some physical energy. We want to expend the extra physical energy. And when you think back on what I just talked about in terms of contributors, we're trying to address a number of those contributors. We're trying to address boredom. We're trying to address anxiety. We're trying to redirect the mind, so we don't get that random, unfiltered kind of reaction. Frequent positive touch. We want them to understand and feel our physical connection. So holding hands, giving hugs, pats on the back. We can limit where we stand and all those kinds of things to protect ourselves, but at the same time, they need physical touch just like we do. And so the more we give positive touch, if it's confined in a way that transitions back to activity and redirection, this actually serves us in terms of the unwanted sexual inquiry. Limit external triggers, and that's a clear one. So pay attention to what's on TV. As I said earlier, mention to hired caregivers about appropriate apparel. Therapeutic fibbing. So, there's a million ways to say no. And it may be, I'm not feeling well. It may be that there's, a medical issue and the doctor said no activity for a while. It may be that you're anticipating someone stop by. It may be a million things, but therapeutic fibbing works. Or it may be you need to get something done and you actually need their help to get it done. So you're in that way, you're not only therapeutically fibbing, or maybe it's not even a fib, but you're also redirecting into an activity. When you use redirection, it's also important to integrate those topics that are what I consider to be security blankets, important aspects of their identity. Remember when we did this, I was thinking about the other day, how many miles you've ridden on your bicycle, over the course of time. How many marathons was it? Or I was thinking about how hard you worked in life. You were so successful, you should be so proud, because we're trying to affirm the parts of them that they feel good about, even as we understand sexual expression may have been one of them. You want to stay calm and non-reactive. And what do I mean by that? Don't get angry, no judgment. You just want to stay calm and try these other things: redirection, therapeutic fibbing. It may be even, hey, I need to, I forgot to water the lawn. I need to go out and do that. I mean, it can really be anything. And if it takes you away just to stay calm a bit, that might be a good thing. Even I want to take a bath first and then move on to something else. This idea of, what about if I really do want to engage in sexual expression with my spouse with a moderate dementia? Is that okay? Does it cross any line in terms of ethics to have sexual activity with someone with moderate dementia? It's a tough one. By and large, the answer is no, but we've got to pay attention to a number of things, because what we don't want to do is add some element of distress. We don't want to force something on someone who doesn't want to be involved in that kind of activity, and yet at the same time may or may not be able to express it. So there is a time where sexual expression needs to stop. And again, that goes back to the loss of it. But where do we understand that line to be? So we think about some questions. To what extent is the person involved in or capable of making their own decisions? And I don't mean all decisions, I don't mean the ins and outs, but would they generally know, yes, I want my daughter to take care of my finances, yes, I generally can say yes or no and it be consistent. And does the person with dementia have the ability to recognize you? So if they are not recognizing you as their spouse, it may be at the occasion that it might not be right to initiate sexual expression with them. Now, if they think your boyfriend, somebody with a relationship, if they're responsive, then it may be okay. But really, that recognition is something to consider as we're making these decisions. Is the person with dementia capable of expressing their views and wishes within the relationship, verbally or non-verbally? When they're distressed, are you paying attention and stopping? When they say no, can they say no? And if either verbally or non-verbally they cannot express their wishes, then sexual activity with them probably is not something that should happen. And can the person really understand what it means to be physically intimate? Is there some mutuality in this experience? And if there isn't, it may be that this is the time for sexual activity to stop. It is a case-by-case situation. It is hard to know. Generally, what you're asking yourself is this reciprocal in some way? Is this distress provoking for them or for me? Is the person at least generally competent to understand what's going on? Intimacy can continue for a long time. Again, it's based on that person's reaction and general understanding. And I want to say intimacy does not have to include sex. So even when sexual activity has to end, there's intimacy is in all kinds of forms. It's in hugging, it's in touching. It can be in the way you look at each other. That it's important to continue a relationship as a spouse, even when sexual activity is no longer available. Attend to the good moments. It's really about those connections between the two of you. Don't lose them in the losses. Pay attention to those moments. I have seen such beautiful moments between people where you are in family situations and you just see the person reach out and hold hand and look at them, and you think how beautiful that is. Recognize those moments. Can be navigated in long-term care facilities, and there are people who enter assisted living at stages where continued sexual expression is still absolutely possible. Sometimes that has to be navigated with the facility staff. There might need to be some dialogue about that, which can be uncomfortable, but it certainly can be navigated. Sometimes that means, taking them out on pass to bring them home. Sometimes that means just asking for a do not disturb sign, that kind of thing, but it can be navigated, again, if these other, questions are answered, if it seems to fit for your situation. And then when that kind of physical intimacy is not possible anymore, certainly find support that allow you to talk about that loss. And maybe that's in a support group where there's lots of spouses who understand exactly what that means. As always, if you have questions, concerns, and you want to process that and talk about that, please know that we're available. All you have to do is get in touch with us, and we're certainly willing to set up a time to talk. So take good care, and I hope we'll see you again on another Mindful Minute.